All right, everyone, welcome this morning. We're going to be looking at this session here. We're going to be taking a look at your employer benefits, the exchange, doctor care, and quirky rules to adhere to. For first-time purposes, please refer to your program. For time purposes, rather, please refer to your program for our panelists' bios. And I'd like to just do a quick introduction of them. So, to my left hand, if you could just raise your hand when I announce who you are. I have Marisha Taylor, who's the Regional Director of BASIC, an HR solutions firm that specializes in employer compliance and administration. I have also with us today Chris Priest from the Michigan Department of Health. Chris is the main liaison with the various state departments to implement reform in Michigan. I have Dr. Scott Eathorne, a primary care physician affiliated with St. John Health Systems and working with the hospital systems to address healthcare reform. And I also have Alisa Bennett, who is the manager of healthcare reform team at Blue Cross Blue Shield of Michigan. So thank you all for joining us today. Okay, getting started. I'm going to kick things off. So there's much discussion as to the future care for hospitals and doctors related to implementing reform. What changes can we expect to see as far as patient care? Some doctors are discussing a concierge model where you pay a doctor fee per year for unlimited care. Are these rumors, or is this the way we may see treatment going to change? I'm going to direct this to Dr. Eathorne to kick things off.
Thank you. I'll start by saying that no, concierge care is not a rumor. It is a very real entity, but it probably means different things to different people. So I'll just take a few minutes to talk a bit about what it means to physicians, and then certainly to all of us as consumers and you as business owners to your employees. There's a movement right now by a few national organizations that are looking to engage physicians to transform their practice into a concierge-type practice. And it typically takes a mature practice, primary care practice, to move in this direction. But essentially what it does is it provides access to care. And I just want to point out it's not unlimited care. Any patients who are members of that practice still need to have a primary insurance. But they pay an additional premium really for access to that provider in their time. And what we typically talk about is they get the physician's phone number, and that may be for calls anytime. It may be for, in this day and age, texts, other access, in addition to usually some other perk, if you will. It might be an executive-type physical or something along those lines. And so we are seeing a growing interest in this, particularly amongst consumers who perhaps are tired of the type of care that they're getting in practices where waits for appointments may be too long. They may not have the type of access they want to their provider. And so there is some movement in this direction, but quite frankly, there's not a great demand for it, only because most people are having difficult enough time affording insurance as it is without having to pay an additional premium of anywhere from $1,000 to $2,000 to $3,000 on top of their existing coverage. The real issue, though, I believe, as a provider, and this is really the work that we're doing, working with the hospitals and physicians, is, shouldn't our healthcare delivery system really be directed to deliver concierge-type care, and what does that eventually look like? And really what we're talking about is how do we improve access to care to meet the needs of the population, our patients, all of you, going forward. And we need to think non-traditionally too, because the notion of office appointments, telephone calls are becoming very outdated, and there's more and more evidence that using other means of communicating and providing care can be just as effective, if not more effective, in helping to manage individuals. More importantly, I think there's going to be a growing demand for that amongst all of us as consumers who have grown tired of the lack of a service orientation of this industry. So this isn't really something new. It's been going on for a while. We see hospitals moving in the direction of providing concierge-type service, redesigning their facilities, private rooms, if you will. And we see more primary care providers establishing different technologies to improve the access of their patients to them when they can't meet the direct face-to-face needs within their practice.
All right, thank you, Dr. Eathorne. Okay, my next question I'm actually going to direct to Marisha and to Alisa. Please define and explain the pros and cons of defined benefits and defined contribution plans for health insurance coverage. Let's start with Marisha.
Thanks, Jennifer. One of the things I'd like to just kind of briefly start out with is I feel that we're kind of at the crossroads we were in the 70s with pension plans. Many employers at that time were offering pension plans as a defined benefit. Those defined benefits really became to a point where they were just unsustainable, and many employers had to look at multiple options or different options to provide benefits to their employee through more of a defined contribution. Thus, it kind of went down the road of 401ks, where employees were provided the defined contribution, whether it was a matching or straight dollar amount, to then put money into 401ks, invest their money, and do things along those lines. Healthcare has really moved in that same direction. The defined contributions that employers are able to offer have, in many companies, become unsustainable. And they're looking at more of a defined contribution option to provide to employees to allow them the flexibility and options to go out and purchase their own insurance. So things have definitely changed. Definitely it's a place we've been before. It's just looking at healthcare in a different way. The pros and cons, of course, is it does provide flexibility for the employee to purchase what's important to them. However, many feel that it is at a lesser amount than was being offered through the defined benefit.
Alisa?
Thank you. I'll just add to that. These two different approaches are really employers' attempts to control costs. I think that's what everybody is looking at overall in the short and the long term, is how can we get a better handle on our costs. So when it comes to defined benefit, in the past, employers who offered very rich benefits didn't have much cost sharing on the part of the employee. What they may have found is they didn't have a very hard time with attracting talent to their company because they were offering these rich benefits. But over time, what they may have seen is, and this is one of the cons, is something called moral hazard, or just high utilization because those benefits feel free to the employee because they don't have much of a cost share. So when employers look at defined contribution, it's an attempt to get use fixed costs versus variable costs in terms of the benefit approach, and then giving the employee more choice and a little bit more control over the type of plan that they choose, if they're offering a suite of benefits that they can purchase if they give them a fixed dollar amount. Depending on the type of plan that is offered, in the case of high deductible health plans, which a lot of people have moved to those in the last several years, in those cases, they don't really find that consumers are using that in the way that they envisioned. So some of them use those plans only when they get very ill, instead of using it for preventive services. In some cases, those health plans don't really have a strong preventive service benefit. So using both approaches, coming somewhere in the middle is probably where employers are going to try and go, having that flexibility, but also having a good handle on how much they're going to spend overall on healthcare benefits for their employees, and giving them information so that they're able to allow them to be informed consumers and choose a plan that is best for them and their families, whatever their needs may be across a range of needs. Blue Cross is able to accommodate both of those solutions by offering both defined benefit and defined contribution choices for employers.
All right, Alisa, thank you. I'm going to direct this next question to Chris Priest. So let's discuss what our options will be, and when the exchange is implemented. What are all the options within the marketplace? We're also hearing about private exchanges. While an exchange is only one option for a human resource company executive to choose from, how do you think exchanges will impact the marketplace? More specifically, are we ready to implement an exchange here in Michigan?
Well, the answer to the last question is yes, we're ready, but we're not doing one, so that's why we're ready.
Right.
So, I mean, the federal government is building our exchange in the state of Michigan. We'll be one of 33 states that operate an exchange under kind of federal, well, when I say we'll operate, the federal government will operate it. So, yeah, we're ready, and we're ready to build a state-based exchange if we can get there. But that is, and that still remains our preference. But in terms of options on the public exchange, private exchanges are going to start sprouting up. It is, I think that's going to be a little bit more time. It's not going to come as, I think it's quick. You're already seeing some private exchanges start to pop up, but I think there'll really be an effort towards it on the private side, kind of over the course of the next, few years. On the public exchange, really you're talking about small group, which is, 50, under 50 employees, and the individual market. Choices on the small group side will remain pretty similar to what is offered in the marketplace today, and that's because there has to be a baseline of benefits in the exchange for all plans offered in the exchange, both on the individual and small group sides, what's known as the Essential Health Benefits Package. Well, the benefit package that was chosen here in Michigan is based on one of the largest small group products already offered in the state of Michigan. So there really is kind of a baseline that can be offered. There'll be some variability here and there. I mean, the carriers have some opportunity to be pretty creative with some of their products they're going to offer on the exchange on the small group side. But the bigger change that you're going to see, especially if you're a smaller employer and you're looking at dropping coverage, is really it's on the individual market. Because the individual market today doesn't have a lot of the requirements that are, at least in Michigan, don't have a lot of the requirements that are currently applied to the small group side. So to give you an example, I think for those of you who are in the last session I talked to, this is the example I use quite frequently. Under 40% of individual insurance plans today cover inpatient maternity. Now that is a mandated service. So when you hear about the Affordable Care Act and things like that, you are getting a lot more benefits in the individual market, but that's very different from the products you're going to see today. You will see standardization at some level across the benefit packages because there are requirements around it. You'll see some variation. Carriers have the opportunity to adjust their products and their plans so that they can make it more attractive for individuals. But generally speaking, you're going to see on the individual side, bronze, silver, gold, and platinum, same on the group side. Bronze covers the least and costs the least. Platinum covers the most and could cost the most. And generally speaking, you would be able to, as an individual or employer, go in and select plans for yourself or for your employees, depending upon how you were shopping. But generally speaking, there'll be a lot more benefit standardization across both the individual and small group markets. That should make comparison shopping relatively easy. But I can't really tell you how that comparison shopping is going to happen today because the exchange itself is being built by the federal government. And that's going to be one of the key features that they will be constructing for Michiganders to utilize. So it's kind of, I think you're going to see a lot more standardization. Private exchanges are really going to start to creep up. I know Blue Cross is working with Bloom Health and other folks to do their own exchange. I think you're going to see private exchanges really impact kind of the larger groups over 100 in all likelihood. Not to say that they won't try to offer coverage in the individual and small group market too. I think the compelling thing with especially the individual market is the public exchanges offer tax credits that can be very, very rich. And that attracts, can attract a large number of individuals who currently today primarily don't have coverage. So I think that's kind of what you're going to end up seeing.
Okay. I know it's been a roller coaster ride here in Michigan,
Oh, yeah.
so it's been changing moment to moment. So I would like to get the carrier's perspective and actually ask the same question to Alisa and your feedback from Blue Cross Blue Shield and what you're doing in planning for the exchange role for private exchanges and for the public exchange as well.
Sure. So for Blue Cross Blue Shield, we look at the exchange as another distribution channel. So we'll continue to offer plans the way we have in the past, but we'll also be offering products on the individual and the shop exchange. We also have a private exchange that's available, and it is focused really on those larger groups over 100. When it comes to the exchange in terms of that being an attractive option, I think it's really, the only incentive that's really out there for using the shop today is the small business tax credit, and that only applies to very small employers. And that tax credit is available today and really has been underutilized. So we don't expect to see a huge uptick in the amount of employers that go to the shop to purchase coverage. But we wanted to make sure that we were offering an option for those who are interested in using the shop or wanted to take advantage of some of the incentives that are out there. The employee choice factor has been delayed in 2014, so that may be another reason why employers won't look to use it in 2014. They'll wait until employees will actually have the opportunity to select between a various number of carriers instead of just having to choose one. And if Michigan follows Massachusetts' example, we won't see a huge uptick in the shop, but we will see a great amount of individuals going to the individual exchange to purchase coverage there, especially from some of those groups who decide that it's no longer sustainable for them to offer group coverage and they actually drop coverage.
Yeah, we'd agree with that. Our projections are that the small group coverage will be very, very small. That really the action, if you will, is on the individual side. I mean, that's really what it is. And that's the same experience that you've seen in Massachusetts and other places. I mean, even states that have a shop exchange like Utah, I mean, very small enrollment and things like that. No one really has figured out the small group aspect of an exchange yet, particularly in the world between the large groups and the individual side. It's a little bit more complicated.
So I think a lot of people will rely on the same sources that they're using today. If they're going through an agent or association or chamber, they're going to rely on those same individuals to help guide their decision making.
Right.
Yeah.
Okay. Thank you for that. So the next question I'll point and start with Marissa. There are a few quirky regulations related to reform. For example, last year companies with over 250 employees had to provide their employees with updated W-2s that included value of their specific health coverage. This year, sometime summer or fall, employers will need to notify their employees of the option to participate in an exchange. What are some of these rules that stand out to you in your operations in various perspectives, Marissa?
Well, definitely the things that are currently standing out to us at BASIC, being a third-party administrator of items such as payroll, FSA and HRA, are just definitely some of the things that are affecting those lines of services that we offer. As Jennifer mentioned, the groups with over 250 or more employees having to report the information on the W-2s was a very big thing for us and for our groups after the beginning of this year. Some of the other things that have definitely been on our radar at BASIC is plan years that are starting after the first of this year in 2013 that have flexible spending accounts had to adjust their maximum to $2,500. That was a big change for some groups. There had been no maximum previously established. So each group had to amend their plans to the $2,500 and also adjust their summary plan descriptions as well. One of the other things that we see on our radar that takes effect on July 31st is that employers are going to have to pay a fee as well for HRAs. Any group that has an HRA, there will be a $2 fee that will come into play that is due July 31st due to self-funding of the Patient-Centered Research Outcome Institute. They have to help fund that as well. So those are the three things that are kind of on our radar right now based on the services that we provide at BASIC.
All right, Marissa, thank you. Any other comments from the panelists on that topic? Quirky rules, things you've noticed? Alisa?
I would just add that the Medicaid expansion, if the state doesn't pass a Medicaid expansion, there's actually kind of a loophole where those who fall into the category of 100% to 133% of federal poverty level would not be covered by Medicaid. So those individuals would either remain uninsured or have to seek coverage on their own. Maybe Chris can add.
Yeah, and I'll just add, the result of that is actually increased cost in the private market, because that income cohort between 100 and 133 really has higher morbidity rates than a lot of other populations. Well, in insurance, it's all about risk. So if you have a lot more bad risk, you have to offset it somehow, and it's done through premium and it's done through cost. So Medicaid expansion from the employer side is desirable because it can keep costs down. Otherwise, I think you would see, and it's the right thing to do. It saves the state budget money. It saves lives. I think that this is the next kind of debate that we are starting to work through at the state level, whether or not to expand the Medicaid program. Our administration has supported it, expanding Medicaid. and do so strongly. But there are, but this is going to be a critical thing, and really it will have an impact on the private sector, because if those folks aren't in, then there are going to be folks that are still going to want to have insurance, because you hear things about mandates and all this. We're about to see a large amount of what I would say is media blitz around a lot of things with the Affordable Care Act. Just kind of the outreach and enrollment efforts, primarily done by the federal government and outside groups. But people are gonna want to say, what are my options? What is there? And if they're gonna go to a federally controlled exchange, which is what we'll have in Michigan, or they're gonna go to their local distribution channels, I expect agents and our producers will get a lot of questions about some of this stuff. And so people are gonna want to know where to go. People will come into the system. The question is how and what is its effect on private insurance? And we think private insurance, we think that Medicaid expansion actually is a good mitigating factor to keep costs down.
Okay.
Jennifer,
Yes,
if I could just
you.
offer up a provider perspective on this idea, because this is going to be a very disruptive change in the provider world. Most hospitals participate with most insurances, so access to hospital-based care may not change much. But in the physician world, depending on how this shakes out, one, there could be a tremendous influx of folks who now have insurance. And as you know, in many cases, we have a shortage of primary care physicians. Whether there will be enough capacity to accommodate all those folks remains to be seen, and there's a lot of speculation about that. The other thing that happens is each time an employee or a patient changes insurance, there's implications for their current relationship with their provider. So we potentially will see some significant fluxes depending on where the provider community falls out in their participation in various plans as a provider network, and changes there. So we'll see fluxes in our patient populations in our panels, and quite frankly, some of our providers are quite concerned about how this may play out. So still a lot to be seen, kind of a practical nature for anyone who's had an established relationship with their physician in terms of will they continue to still be able to see that physician depending on what their employer does, or whether their physician participates as a provider in all the plans in the network.
But I don't think it's fair to say that that's actually going to happen over the course of the next probably 3 to 4 years. I mean, that isn't
right.
Kind of every provider isn't saying, well, I'm not participating in this on day one. I mean, you really are. This is going to be an evolution over time.
And it's certainly
on a local level.
Right, and it's certainly been a phenomenon that's been in play as well, because there are plans that providers opt in and out of, and so people have to change. So this isn't a new phenomenon. The question is, will it be amplified by the exchange coming to fruition going forward? And I think there's a certain amount of uncertainty to that.
Yeah.
Okay, I'd also like to get Blue Cross's perspective on this same question. What have you seen as far as you've been implementing healthcare reform, and what do you still need to do as Michigan's largest healthcare provider to comply with the challenges ahead?
So I'll just give you a little bit of history on Blue Cross and what we've been doing behind the scenes. In 2010, when the law passed, we created an Office of National Health Reform so that we could have a centralized office that would focus on how do we make sure that we cover all of the new regulations, how do we make sure that there are work streams that are responsible for making sure that we understand the regulations and that we implement them based on those rules and in a timely fashion. So as you know, in 2011, when we were expecting a number of those regulations to come, they were on hold, and again in 2012 because of the election. So we've had to move forward with a lot of working assumptions. We didn't want to wait until the very last moment because that is not a practical approach. So we're pretty well caught up. I think this year our focus has really been, from the employer standpoint, has been on communicating the impact of taxes and fees. We know that that is an area of great concern because there's uncertainty around the financial implications to each individual employer and what that will mean for them in the short and long term. Some of the taxes are temporary and will go away either in a few years or maybe about 5 years. Some of them will go away officially. Others will replace them, I'm sure, depending on how financing of health reform goes. But right now, that is our primary focus in communicating that. A lot of the benefit changes, our products have all had to be changed to make sure that they are healthcare reform compliant, making sure it covers all of the mandatory preventive services, including women's preventive services. I could go on and on in terms of the mandates, but I don't want to draw things out. We are pretty well caught up in terms of the regulations that have been issued so far. And I think at this point, our goal and our efforts are really around communicating all of those changes, making sure that to the extent we need to, we're holding hands with our customers and our stakeholders so that they feel comfortable that we as a carrier are prepared, we're ready to move forward, and we're ready to help them in whatever ways we can.
All right, Alisa, thank you so much. The next question I have is actually regarding the pros and cons of an exchange model. And as we know from Chris's information, and many of you have heard, we're going down the path, it looks like, of this federal exchange. Can you give us some of the peaks and valleys, if you will, on the exchange and what we're about to embark upon, if you know?
For what I know.
Yeah, for what you know.
So, seriously, I'm not joking about that. That's like one of those things the federal government really hasn't given a lot of details yet, so that's why it's kind of funny. So, generally speaking, kind of the general pro really is kind of an apples to apples comparison shopping of health plans for the consumer, whether it be an employer or an individual. So there's that, plus the availability of tax credits. Tax credits both for the very small groups as well as for individuals. The only place to get those are going to be at the exchange. So those things, I think, will drive a lot of volume into the public exchange, particularly this year. You're going to have a lot of things happening at once. The employer kind of pay or play mandate coming on. You're going to have the individual mandate coming on. And then you're going to have these coverage options, which is the exchange or Medicaid. And a variety of other things. And then generally, I think the most overlooked aspect are all the individual market reforms, the reforms across the insurance markets. That's really getting to a lot of the meat of what's happening in the insurance marketplace today, whether it's on exchange or off exchange. But what the exchange affords someone is the ability to go in and compare and gain access to subsidized coverage if it's available to them. I mean, tax credits are going to be available. If we expand Medicaid, you would have Medicaid coverage from 0 to 133% of the federal poverty level. And from 133 to 400% of the poverty level, you would have tax credits available to help offset your coverage. Well, 62% of all non-elderly Michiganders are under 400% of the poverty level. That's a huge number of folks that will have the availability of some kind of subsidized coverage through the exchange. So that is one aspect. Now, there is some downside, and to be clear, we prefer to have a state-based exchange. I think most folks up here prefer us to have a state-based exchange, and we still want that. But I think the federal exchange, first, it's going to be, for lack of a better phrase, kind of boxy. I mean, we're going to have the same thing that 33 other states are going to have. It will be very minimal tailoring to Michigan. With the exception of the plans, but that's where the carriers are going to be doing a lot of work to try to make sure that people know that their local coverage options. The other piece is cost. If you look at a state like Colorado, who's doing a state-based exchange, these exchanges are supposed to be financially self-sustaining. Well, their user fee is 1.4% of the premium sold on their exchange. In a federal exchange, our carrier friends are getting charged 3.5% of premium. So there's a cost differential here. Not the ability to tailor it to what's happening here at the local level and not being able to connect Michiganders with Michiganders. I think that's one of the biggest concerns that we have from a customer service perspective, is being able to make sure that individuals can go out, find local resources, whether it's your producer network or whoever, and be able to talk to a Michigander about what their options are. That will still exist in some form or another, but if you're going through the exchange, a lot of this is federally controlled. There isn't a lot of Michigan-specific stuff, with the exception of the plans themselves, that are going to be offered on there. So, I think that's going to be a challenge. And we're on the same infrastructure that 33 other states are. So if you don't like the website and you want to call the call center, I can't tell you what you're going to get. And that really, quite frankly, is concerning.
I think that's a very good point. I know our association worked to lobby with your team and many other teams out there regarding trying to make this a state-based exchange, and obviously we'll keep up our work with that. But I would like to get Alisa's comments as well from the carrier's perspective, if we could, just a few minutes.
Sure. I think Chris covered it in a lot of detail, but I just wanted to add that in terms of the pros, that consumers will have essential health benefits, a package of benefits that are guaranteed to them no matter which product they choose on the exchange, and that's something that's new for them. Obviously, a simpler way to choose by having these plans categorized in metal tiers so they can see pretty much right off the bat from a price standpoint where they want to go, whether it's bronze because they really don't want to pay much out of pocket initially for the premium, or platinum because they'd rather pay less at the point of care. Having the subsidies available to them that weren't available to them before is an attractive feature as well. Guaranteed issue and a lot of the insurance reform that Chris referred to, really for Blue Cross, it represents a huge improvement over the environment we've been in for the last several years because we were the insurer of last resort, and this levels the playing field for us. And for the consumers, I think it gives them options as opposed to saying, you know, Blue Cross will take you because no one else will. Now they get to choose. We're still hoping they'll choose Blue, but for the right reasons. When it comes to cons, obviously the prices of these plans, now that they're fully loaded with essential benefits, they're going to be more costly and less affordable than they have been in the past. The penalty to not have coverage or not carry coverage at all is very low initially, so that's not a huge driver. So we think that the uninsured problem will still be a problem through 2016 when the penalty is a little bit higher. But those are the things that that I thought were
Some very good points
important
there.
I will say that, you know, the essential health benefits piece that you talked about, that really, I mean, the individual market is where that's going to happen. I mean, small group, already pretty similar. I mean, a lot of the essential health benefits package that is kind of the baseline for Michigan, what's going to be offered on these things, it's all relatively similar, even compared to what's in the market today. There are a few, few points here and there, but they're minor. But the individual market, I think, is where really you'll see a lot of the more cost fluctuations that, to expect, instead of a small group, for those of you who are between that group of 2 and 50.
All right, Chris, thank you. The next question I wanted to pose, I think, affects many of our members who are here today. And I'm going to start with Marissa on this end. If you were a 100-person company, what changes would you make in order to prepare for reform? And then let's look at a smaller group, let's say 40. So can you give some balance on what an employer group should look at as they're planning?
Well, I think the big thing is that many employers are going to have to look at is really define the strategy or the direction or philosophy that they want to move in. Many employers have seen all the statistics out there about the number of groups that may be just moving their groups to private or public exchanges. And those are the types of things that employers are going to have to look at, whether it's a group of 100 or 40. What is important to them? What keeps their good employees there? Many companies have and will continue to use benefits as a way to attract and retain employees. And as a company, I think there's going to need to be a lot of really good discussions on what keeps our good people here. And is it our benefits? Is it the pay rates? And from there, devise with their, whether it be their insurance agent or consultants, a plan that will make sense. Because today, we all know that price is also very important as well. So looking at what type of fines and penalties may be in place, and then devising the best way to keep and attract and retain your good employees. So I think just in taking a step back, whether you're a 100-life group or a 40-life group, it really, you need to look at what your philosophy is, what direction you're moving in, and what's important to you as your company as far as keeping your good employees there. So I think that's the direction many employers need to take as a first step.
All right. Did you want to comment, Alisa?
Oh, sure. So I was here for the last part of the previous session, and one of the first things I would do is count make sure that you know for sure whether you have a 100-person group or a 40-person group. It matters what category those employees fall in, if they're part-time or full-time. So it's important to use the new definition and methodology, and I think the tools that you're offering are fantastic to really help employers with being able to accomplish that. My next note was about benefit strategy, so I won't go into detail on that, but in the short and long term, benefit strategy continues to be an important consideration. Also, having some kind of consultant, whether it's a tax advisor, an attorney, you know, us as a carrier, we get asked all kinds of questions, and there's really a limit to the extent that we can advise our customers about what we're able to assist them. So it's important that if you don't have one already, that you have an attorney or an accountant or tax advisor that you can consult with about some of the financial implications of the future. And then the last point I wanted to make was just about communicating. I think it's going to be very, very important for you to communicate with your employees, whether it's doing a survey, whether it's asking them, doing a town hall style session to ask them what's important to them, so that you do know what things are important to them as you're developing it or changing your benefit strategy for the future.
All right, the next question I'd like to direct to Dr. Eathorne. In relation to our relationships with doctors, what should we as individuals be doing now to prepare for reform? Many are joking about getting surgeries or health exams in before it kicks in. Hopefully this is not true, but how should we be preparing? And I'd like to get your feedback.
Yeah, I think that notion of kind of getting that surgery in under the timeline kind of relates to some of the folks that we've seen over the years with high deductible health plans. They meet their deductible and suddenly they come in and they need an MRI for that sore knee and they want to get this selective surgery done. So I don't think that's going to be as much of the phenomenon going forward. But one of the things that we're really encouraging, and it's really part of the healthcare delivery system transformation that's being fueled by the insurance or payment reform, is patients, people, we all need to be much more engaged in our healthcare. This notion of a paternalistic delivery network where the physician knows best is really a past notion, and moving forward, patients have to take much more active role in their care. So that's probably first and foremost, and a lot of what we're really encouraging is that establishment of relationship with a primary care physician, whoever that may be, so that you have somebody who can help navigate some of the waters here, because as we move from a marketplace that's had a history of first dollar coverage for care and little knowledge of most folks of the actual cost of care to one where we've seen increasing out-of-pocket expenses, people are going to become much more discriminating consumers of health care, and to have a true partner working with you with aligned incentives as we see payment reform moving to, unfortunately use that somewhat worn out term, I think just makes sense. The idea too of focusing on preventative health care as opposed to chronic care management, although both are important, is going to be key, and whatever benefit design can do to help encourage and create the right motives for addressing health risk factors is really going to be key, and it helps us as providers to have those conversations and help motivate patients as well. So that's important, and it's important as well for consumers to understand that more is definitely not always better, particularly in healthcare, and we know a lot of the expenses in healthcare that are probably unnecessary relate to care that isn't necessarily appropriate, whether it's diagnostic testing, some of the end-of-life care issues that are out there. And last but not least, which I think has been a common theme, is for associates and employers to really know and understand what their benefits are, because so many times we see folks coming in who really don't understand what their benefits are, and oftentimes it's had this confusion, and many times it's during a time when people are most vulnerable too. So really understanding what your benefits are up front as you evaluate the various plans that are available is really going to be a key message. As an employer, your ability to help your associates, your employees, to navigate these waters is really going to be key, as well as to encouraging those healthy lifestyles, healthy workplaces, to avoid the expensive care that oftentimes comes from not living such a healthy lifestyle.
Okay, well, I think I'd like to take a couple questions from the audience as well. So I'm going to grab the microphone and I'll come around the room. Please stand up and ask your question, and we'll take a few moments to do that. Get some feedback from our panel. Okay. So who would like to kick it off? Anybody over here? There we go.
Doctor, I'd like to ask you the limitations you're going to have in terms of providing services, treatment to people that are 70 years old or older from the Healthcare Reform Act. Are you aware of things that you're going to be limited on practicing on those patients?
Such as?
Well, I've heard from a standpoint of a neurosurgeon not being able to perform a surgery on a bleed in the brain for someone that's 70 because they've got to have a panel in that hospital that are non-doctors making a decision as whether he can perform that surgery or not.
Certainly, we're aware of some of those discussions of that going on. I am not aware that any of that has actually been mandated or will be part of what comes to fruition. So if folks have other knowledge of that coming to bear, I'd certainly be interested in hearing more about that. I think a lot of that type of notion feeds into the notion of the death panels that we've heard about, making decisions about who's going to live and who's not going to live. And again, I think that becomes a little bit more of a political argument than a practical argument. However, when you get into benefit design, there's certainly going to be issues about what's a covered benefit and what's not, and that certainly is going to limit some of the care that's provided, potentially based on coverage, but that's in many cases no different than what's out there.
Okay, Dr.
currently.
Eathorne, we're going to move on to the next question that we have.
Question on the individual stuff we got going, and it's addressed to the penalty that you mentioned. You know, it's really small in the first year. It is really small. It's $96. Why is anybody going to, I don't care what your subsidy is, what tax credit you're getting, why would an individual spend money when my fee is $96 and I can join later with no pre-existing condition? How is that going to impact the insurance carriers?
Well, I think that it's really a matter of personal choices, and there isn't a whole lot that we can do. The prices of the products are going to be what's reasonable and what we're allowed to charge within the guidelines. So if an individual decides that they would rather go without the coverage and take that chance, as they have been doing in the past, and pay that $95 fee at the end of a year, then there's not a whole lot we can do to force them. We can try and make it more attractive to them. We can tell them the implications of having an episode or an event that could be damaging to them financially by not having the coverage. But there isn't a lot that we can do that we haven't already done. We've already tried to lobby for changes and so forth, and those have not been successful. So this gradual approach to increase the penalty over a few years gives individuals time to put aside that money or whatever it is they have to do. I think that having the subsidies available will be the most attractive feature for those who fall into that income category to pursue coverage where they haven't in the past. But it may not be as compelling as only paying $95 and taking your chances. So we're going to miss out on some of the younger people who may not have the salary or the income to be able to afford coverage at the cost that it's going to be in the future.
Okay, Alisa, thank you. We have time for just one more question. Anybody from this side of the room care to ask a question over here?
Alicia, back when President Obama was trying to muster support for health care reform, he indicated that if people had a plan and they wanted to keep it, it would be called a grandfathered plan, and he'd be allowed to keep that plan. How does Blue Cross stand on allowing those same people to keep their plans going forward with their new portfolio of products that they're putting out in 2014?
So we would pretty much categorize that as political rhetoric, to be able to keep the plan that you had. In the small group market, there have been so many requirements of the ACA that it is really impossible to keep the plan that you had in the past. For our small group portfolio, all of our products are changing. They will be healthcare reform compliant. They will have all of the required benefits. But for individuals who fall into that category of having a fully insured plan with us, they will not be able to grandfather into 2014. That's just not. No. You might have to take that up with President Obama.
All right, everyone. I wanted to just thank our panelists this morning. I do appreciate all of your insight, all of your valuable points and everything that you shared with us. The session, I think, has given us a great look at employer benefits and all the components that we talked about. I want to thank you again for joining us. The next session is an expert roundtable, during which today's experts will answer your questions beginning at 11:30 in our ballroom, at which time the luncheon will also be served. And please don't forget to visit our exhibitors and our sponsors at their tables outside in the hallway. Thank you for joining us today. Have a great day.